Ideas that pop up to our mind when facing a case like this. What are the possible causes? Any consequences? What is the incidence of future short stature? When to decide to give growth hormone? What is the workup and management? And finally, what do we tell the parents who have a baby born small for gestational age? First of all, the definition of SGA is a birth weight and or length less than 2 standard deviation score below the mean for age and sex. And the definition requires accurate knowledge of gestational age, measuring weight, length, and head circumference at birth, and this is very important, and a cutoff against reference data from a relevant population. About 5% of newborns are born SGA, and 95% have a normal birth weight and length, and there are 3 subclasses for SGA, either SGA for length or weight, or both weight and length. It's very important to note that SGA is not a synonym of low birth weight or intrauterine growth retardation. Low birth weight is an infant born weighing less than 2.5, independent of gestational age. IGR is defined as a slow fetal growth based on 2 ultrasound measurements, and it may lead to SGA. And preterm infants are those born less than 37 weeks, and catch-up growth is affected by the dual effect of preterm birth and SGA. And the preterm SGA take a longer time to catch up more than those who are just SGA. Now, looking at the pathogenesis of short SGA child, it is a very heterogeneous, complex etiology. You can see here the causes are either due to maternal factors leading to reduced maternal stature, or fetal factors including those syndromic and chromosomal aberrations, and in about 40%, which is a quite high percent, it's idiopathic. It's very important to note that there is metabolic programming in SGA infant, and this predisposes to metabolic syndrome. Epigenetic changes lead to cardiovascular remodeling, and this is the main factor leading to the complications and the long-term consequences in those babies. So how does SGA predispose to metabolic syndrome? SGA leads to metabolic programming, as we have said, and this leads to redistribution of nutrients, fetal and placental hormonal changes, postnatal growth environment, leading to changes ending by obesity, type 2 diabetes, abnormal glucose metabolism, dyslipidemia, ending by metabolic syndrome. And it's more risky in SGA infants who catch up very quickly. So overfeeding is not recommended in those babies. Another important question, does SGA affect the pubertal onset or not? SGA indeed, in those with rapid postnatal gain, increases the insulin and IGF-1, which decreases the sex hormone binding globulin, phosphorylation of P450, C17, and increase in LH, which is earlier than those born adequate for gestational age. And this leads to excess androgen synthesis in the adrenals and the ovaries, resulting in adrenal androgen secretion, what we call early puberty. In some of them, hyperandrogenism disappears by early adulthood. In others, there is a high risk of polycystic ovary syndrome, and that's why it's very important to diagnose and spot those with SGA. Also, pubertal onset is normal but earlier than those for gestational age, leading to shorter final height. Another important point is a neurodevelopmental sequelae in those born SGA, affecting motor skills, cognitive function, IQ, speech delay, and behavioral problem. So you can see here that metabolic programming and epigenetic modification with postnatal abnormal nutrition lead to a very long list of complications in infants born small for gestational age, especially those who catch up very quickly. And here you can see assessment of short SGA children, which is quite similar to what we do in any short child, but most important here is growth hormone stimulation test is not indicated in infants born SGA. If you are sure that the baby was born small for gestational age, we do not need to do growth hormone stimulation test. And this is simply because growth hormone deficiency is very rare in those children, and this is the joint SP, PES, and GRS consensus statement. So what about the alterations in the growth hormone IGF axis in short SGA children? As I previously mentioned, low growth hormone is extremely rare, and that's why we do not screen for growth hormone deficiency except in selected cases. The most common is growth hormone resistance, high normal growth hormone and high normal IGF-1. And growth hormone therapy increases the final adult height by more than 1.25 standard deviation, and it normalizes the body composition as well. Now, let me take you to the same scenario that I started with. The full-term baby born SGA. The height is minus 2.8, the BMI is plus 0.1, and the mother came to me at the age of 1 year requesting growth hormone therapy. She asked me to write down growth hormone for this child. What is the correct decision? Would you like to start growth hormone for this baby at 1 year age? Who would like? Can you raise your hand, please? Does anybody like to start growth hormone in this baby, being SGA? Thank you very much. Nobody raised hand. Yes, we do not need to start growth hormone, simply because the height prognosis is excellent. 85 to 90% of those babies catch up at the age of 2 to 4 years spontaneously, while 10 to 15% do not catch up the height and will require growth hormone. So if you face an SGA infant, don't rush to give growth hormone except after the age of 2 to 4 years. Now, of course, growth hormone therapy is approved for short SGA children who did not catch up at the age of 2 to 4 years. And as you see, FDA approved it at the age of 2 years, while EMA approved it at the age of 4. And the dose here, you can see that in EMA, the dose is different from FDA, but this is the dose range that we start with according to severity. Indeed, long-term growth hormone therapy optimizes the final height in children born SGA, and the higher the dose, the earlier the onset, the more the response. On the other hand, discontinuation of growth hormone leads to what we call catch-down growth. So if we stop growth hormone in those children, they decelerate their height, as you see in this chart. Now, the question is not only to grow, the question is how to grow right. We need to grow right, not just growing the child. And that's why there are predictors for catch-up growth in SGA infant, and there are higher chances of gaining better height and catching up according to early age of start of growth hormone, taller parents, higher length SDS, higher birth weight, more duration of treatment, and the baseline bone age. So these are the decisive factors affecting response to treatment. Of course, it's very important to continue growth hormone therapy until complete epiphyseal closure in order to optimize the final height. And it's very important to note that growth hormone therapy is generally safe in short SGA children, except with very few syndromes when it's contraindicated, like Bloom syndrome. Growth hormone not only improves the height, but it improves metabolic profile. It improves the lipid profile, it lowers the blood pressure, increases the lean mass, and decreases the fat mass. It improves the IQ, the final adult height, and the bone mineral density. And that's why it's very important to be given to those born short SGA. So we need to design a timed plan for SGA infant. And here you can see the timings when we need to take an action. We need to do regular monitoring of weight and length monthly till the 3 months of age. If the child is catching up, avoid excess weight gain to avoid metabolic syndrome. If there is lack of catch-up, do endocrine assessment and start growth hormone if necessary. And don't forget to measure the blood pressure, lipid profile, blood glucose, insulin, A1C, and the bone age as well. Now, another quite common story that we see in Arab countries, the story of this 9-year-old girl. She was born SGA. She came with short stature and early puberty. She's very short, Tanner breasts 3. Her growth hormone stimulation test is normal, and the rest of the labs are normal. And look at the bone age. The bone age is advanced, so this girl does not have enough time. What would you like to do for this girl? Would you like to wait? Don't do anything, just follow up the girl? Or start growth hormone only? Or give growth hormone and GnRH analog to stop the puberty? Who would like to wait? No one will wait. Very good. Who would like to give growth hormone only? Okay, 4. Who would like to combine growth hormone and GnRH analog? Okay, most of the people. Okay, let me tell you, the answer is controversial. Of course, we will not wait. We have to help this girl. Some would give growth hormone only. I would go for delaying the puberty for a while, especially that the bone age is fine. We can delay the puberty and combine it with growth hormone, but let me tell you that this is an off-label indication. This is not FDA approved. Remember, please, that SGA could be the presentation of a chromosomal aberration or syndrome. And you can see here a very long list of syndromes presenting with SGA. So don't forget to look for dysmorphic features in any baby born SGA. This is the story of a 13-and-a-half-year-old girl who came to me with short stature, delayed puberty. She was born with a low birth weight and length, swelling of the dorso of hands and feet, mathematical problems at school, and otitis media. And this is the chart of the girl. She was short since birth, in infancy, childhood, and adolescence until the time I saw her. Yes, thank you very much. Excellent. Thyroid function, growth hormone, celiac screening were negative. The bone age is delayed. The GnRH test revealed high FSH-LH, low estradiol, and this is hypergonadotropic hypogonadism, meaning that there is an ovarian problem. The ultrasound showed horseshoe kidney, and the echo is normal, and you answered the question. What is the missing investigation? Thank you very much. Karyotype, of course, we should have done it. And the girl turned out to be a 45X Turner syndrome. Don't forget to do a karyotype in any short girl, even if not dysmorphic, and in the presence of lymphedema as well. And based on the clinical practice guidelines for care of patients with Turner syndrome, it is advisable to start growth hormone in those girls, maximum by the age of 4, and later on we add sex steroid. What about this cute little boy? This is an 8-year-old boy who came with short stature. He was born SGA, learning problems at school. He has a left undescended testis. He's dysmorphic. He has ptosis, low set ears, webbing of the neck. The birth weight and length are low. His thyroid, growth hormone, celiac, karyotype, everything is fine. The bone age is delayed. He has pulmonary stenosis on the echo. What's your diagnosis? Thank you very much. Excellent audience. Yes, this is Noonan syndrome. He looks like Turner, but this is a boy. This is an autosomal dominant condition and not a chromosomal aberration. So the suggested treatment, growth hormone, is approved for Noonan syndrome. And recently, last year, it was approved by Europe as well. And they need larger doses in addition to sex steroid replacement therapy. What about this sweet boy? This is a 4-year-old boy who came with short stature. He was born very small, 850 grams. The birth length is 42 centimeters. He has triangular face, frontal busing, discrepancy in the leg length, café au lait patches. Thyroid, celiac, growth hormone, karyotype, everything is completely normal. What's your diagnosis? Thank you very much. This is Russell-Silver syndrome, and Russell-Silver recently was FDA approved, again, indication for growth hormone therapy. What about this 12-year-old boy who came with short stature and obesity? He was born SGA, and then he started to develop very rapid weight gain, difficult feeding. He was a floppy infant. He developed hyperphagia and progressive weight gain at the age of 3. The mother reported having intellectual delay and learning problems as well. And he has small hands and feet, and as you see, the genitalia, he has micropenis and small genitalia. What is the suggested diagnosis here? Thank you very much. This is Prader-Willi syndrome. And if you look at the growth chart, he was born SGA, he became a short child, and then he started to develop very more deceleration coincident with adolescence in the height. And looking at the weight, he developed very fast weight gain starting from the age of 3 years, to the degree that his parents reported that they had to lock the refrigerator to stop him eating. They couldn't control how much he eats. He keeps eating all the time. Impaired growth hormone IGF axis is a constant feature in Prader-Willi syndrome, and they have resistance rather than deficiency. And of course, there is a very long list of comorbidities that we need to screen in Prader-Willi syndrome. And this is what we did in this boy. We found low T4 and TSH. This is central hypothyroidism. The cortisol and ACTH were normal, and the boy had impaired fasting blood sugar and oral glucose tolerance test. Of course, growth hormone is approved for Prader-Willi syndrome at the year 2000, and there are a lot of benefits in those children, not only on the height, but on the shape of the body, the composition, the motor function, and the psychosocial development. But, and this is a very big but, don't forget to do full assessment before starting growth hormone, polysomnography, ENT examination, and thyroid function. So you need to take a guided decision in those children. My last case is this 8-year-old girl who was born SGA. She had short stature, obesity, and she came to the emergency room with carpopedal spasm. She has learning problems. As you see in the photo, she has short toes and skeletal malformation. The metacarpals are very short. What are the urgent labs? She came with carpopedal spasm. Yes, thank you very much. We did the serum calcium. It was very low. The phosphorus is very high, and the parathyroid hormone is very high. So this is the diagnosis of pseudo-hypoparathyroidism, and this is the syndrome of Albright hereditary osteodystrophy. And here the treatment is alpha-calcidol and calcium, while growth hormone is not yet approved in those children, but it's an off-label indication. So finally, please remember, early start of growth hormone therapy in SGA provides a better final outcome, and it improves the metabolic status of those children. And even more, what if the time is critical at the time of puberty? We need to be fast. And in such a condition, growth hormone effectiveness means a lot in such children. And sometimes we need to buy the time, because if you don't have time, you might be stuck in this very sad story that I see a lot. An adolescent coming after epiphyseal closure, and unfortunately, you cannot go back with the time. I won't be able to help him if he reaches the stage of complete epiphyseal closure. So my final thoughts are, birth weight and length recording is essential. It's very important and simple information that we need to focus on. SGA is defined as birth weight and length, less than 2 standard deviation. Pathogenesis of short SGA is really complex and heterogeneous. SGA could be the presentation of a syndrome and chromosomal aberration, so look for dysmorphic features. 10% of children born SGA do not catch up by the age of 2 to 4 and will require growth hormone therapy. Growth monitoring of SGA is essential for timely referral in those who do not catch up, and growth hormone stimulation test is not needed in those children. Growth hormone therapy is approved by FDA and EMA for short SGA children. Remember that SGA children are predisposed to early puberty and adrenarche and metabolic syndrome, so we have to screen for these abnormalities. Early growth hormone improves the final height and metabolic profile in those children. Long-term follow-up data suggests that growth hormone in short children has good safety profile and is well tolerated. And finally, remember, growth hormone effectiveness counts a lot, especially when time is very tight at the time of puberty. And I really like this quote when doing this presentation. I took it from the Google. Sometimes you make the right decision, and sometimes you make the decision right. And this is what we need to do in those children. So always make the right choice in order to hit the target and reach it properly. Thank you very much for your attention.
الحقيقة دكتور رشا مش عارفة أشكرك إزاي، يعني straight to the point, very clear, very comprehensive, as expected and beyond كمان.
Thank you very much.
مش عارفة دكتور وائل هيسمح لنا بأسئلة، ولا يعني لو في سؤال أو اتنين للدكتور رشا نقدر ناخده من الحضور. هو كريستال كلير صحيح، بس ممكن يبقى فيه برضه بعض الاستفسارات يعني. طب ده بيرفكت. يا سلام.
كما هي العاده دكتوره رشا متالقه دايما.
شكرا.
لا مش انت بتعقديني في اللغه بتاعتك بصراحه دكتوره رشا. الله يخليك. حضرتك بالنسبه للافيلابيلتي اوف جروث هرمون، كان عندي حاله من كام يوم كده وبعتها لاحد الزملاء من اساتذه زملائنا الممتازين، فقال لي مش موجود دلوقتي حالا حتى في التامين الصحي. وطبعا عشان اساسا يبقى افيلبل بره التامين الصحي بيبقى غالي جدا. احنا في مشكله خطيره جدا.
صحيح.
يعني العيان قدامنا مشخصينه ومش عارفين نعالجه. مش عارف راي حضرتك ايه في المشكله دي؟
بشكر حضرتك دكتور محمد على الكلام الجميل الاول، ده شرف ليا ان حضرتك تقول عني كده. الحقيقه هي فعلا مشكله. هي مش كل انواع الجروث هرمون مش افيلبل، هي بعض الانواع فعلا بعد يعني شويه حاجات مشاكل في الاستيراد والكلام ده ظهرت مشكله ان بعض انواع الجروث هرمون مش موجوده اليومين دول، بس اي هوب ان دي ترانزيانت بروبلم، انما في انواع ما زالت موجوده. يعني ان شاء الله هي مش بروبلم مستمره ومش في كل الانواع، لا في انواع موجوده ومتوفره.
هل متاح برايفت وسعره كام؟ يعني لو انا هجيبه من بره لطفل او هجيبه
هو سعره دي هتتوقف على نوعه. يعني احنا عندنا النوع المصري كويس قوي وارخص من الباقيين، يعني النوع المصري
وماله بس يكون موجود.
وعندنا انواع مستورده ثانيه. الفكره كلها ان احنا حسب الدوز اللي انا هكتبها. يعني مثلا التيرنر سيندروم والاس جي اي بيحتاجوا دوزز عاليه عن اللي عنده جروث هرمون، فده هيبقى مكلف اكتر من ده. العيان اللي هو في بيوبرتي هديله دوز اكبر من الطفل الصغير اللي هو مش في بيوبرتي، فهي القصه مش تكلفه معينه، بس في انواع ارخص من انواع، في اقلام، في حقن، في جهاز بنحقن بيه. يعني هي القصه انواع واشكال،
بس تكلفه عاليه جدا، مش عايزه كلام.
يعني هو التامين الصحي الحقيقه بيوفر الجروث هرمون بكل انواعه، بس ليه شروط، ليه بروتوكول معين. يعني مش اي طفل قصير التامين بيقدر يتكفل بيه.
هو بيتاخد ديلي حضرتك مش كده؟
بيتاخد ديلي سبكوتينيوس.
لمده قد ايه تقريبا؟
يعني في بعض الامراض مثلا زي الاس جي اي دول والتيرنر مثلا بياخدوا لغايه الكومبليت ابيفيزيال كلوجر. في ناس بيحتاجوه طول العمر، يعني مثلا الكرينيوفارنجيوما خلاص البيتويتري از دامجد فهي هاز تو تيك ات فور لايف ميتابوليك. فهي القصه برضو على حسب المين دايجنوز.
شكرا جزيلا.
شكرا لحضرتك. ميرسي.
أنا بكرر شكري للدكتور رشا، ويعني هيبقى كومنت أخير يا دكتور رشا لو تسمحي لي، إن الجزء اللي قلتيه في التريتمنت إنه بس إحنا مش بنتكلم على طول، لا إحنا بنصلح كمان ايشوز أخرى من ضمنها الميتابوليك سيندروم. دي حاجة الحقيقة يا ريت تبقى هي المسج بقى اللي هي الناس يعني تبقى مركزة عليها النهارده، ونشكرك مرة أخرى. Thank you very much.
دكتورة ماي. ميرسي.